Greetings. This is Dr. Jim Drzegescu, your CHC Medical Director. We are pleased to provide and continue to grow our CHC Educational Library, which was created to educate CHC members about initiatives and best practices for improving the consistency in delivery of care following clinical practice guidelines. These topics were selected based on their overall value for improving our patients' health. Clinical integration relies on our collaboration with each other in order to have the greatest impact for our patients that we collectively serve. We hope you find the presentations in this educational library useful. We value your membership and expertise. If you have any suggestions for topics to add to this library, please let us know. I hope you enjoy the following presentation.
Welcome. My name is Lauren Mansell, and I'm a physical therapist who is specialized within pelvic, oncology, and lymphedema physical therapy at Palos Health. And we've created this training for you to better understand cancer rehabilitation. An objective for this training is for you to understand prehabilitation, which means to prepare someone for the challenges of cancer treatment. Within physical therapy, we would like to create a baseline and then provide interventions to improve the function of the patient through standard treatment. When treating the effects of cancer treatment, we want to provide surveillance, meaning that we want to take measurements before any interventions have occurred so we know what their starting function is. And then we want to optimize their function during their different treatment avenues, so that we can make sure that we are safely maintaining or even improving their ECOG performance standard. What we have found within evidence-based research is that prehabilitation increases quality of life, improves connective tissue function, reduces rates of lymphedema, and improves bowel, bladder, and sexual health. Oncological or cancer rehab is a functionally based rehabilitation model that is similar to all other forms of rehab after a serious injury or illness. Our interventions focus on improving quality of life and or physical emotional function. Within oncological or cancer rehab, our rehab experts include physical therapists, occupational therapists, and speech pathologists, with some overlapping throughout those three distinct practices. Oncological rehab, or cancer rehab, is similar to traditional rehab in looking at range of motion, strength, endurance, utilizing manual techniques to reduce scar tissue issues, lymphedema management, myofascial restrictions, and the like. Our education is focused on self-care and teaching compensatory techniques. And additionally, we want to strongly empower the patient to take into consideration their ability to affect the cancer treatment. What sets us apart from normal physical therapy is that we're trained in the effects of cancer and cancer treatment, and knowing how those physiological processes and the treatments affect that patient's function. We also want to have assessments and keep into consideration that patients are both currently having a function level, and then we expect for those function levels to decrease based on the cancer treatment they are going through. We want to provide information and education along the spectrum of care, so there's a lot of flexibility within the needs of what the patient needs from their cancer rehabilitation specialists. So that means that they may be in treatment on and off during their care. We will be reviewing articles focused on reducing rates of lymphedema, which is a concern during cancer treatment, and creating a multidisciplinary approach to maximizing function with patients going through cancer treatment. The first study is a randomized clinical trial with 36 people in the intervention arm and 36 in the control. What's really great about this article is that it showed that with education and exercise, gentle upper extremity, gentle active range of motion, breathing program, that there was no rates of lymphedema. With the control group that did not receive education or exercise, that 60% of those 36 women had acquired lymphedema. What's really great is that we know we can influence rates of lymphedema based on education and exercise, and that's done at the onset of treatment. The second study was a surveillance model that was presented at SOGI International in 2018. This study looked at over 200 patients screened with 50 referrals for local optimization. So this was a tertiary hospital that had patients coming from all over the country, mainly the Midwest, even internationally, for specialty adenocarcinoma of the abdomen services. So we looked at over 200 patients. We did have over 50 referrals for local physical therapy and optimization. We followed these patients over time. We found that there was a reduced length of stay after their surgery, that there was a reduced readmittance rate, and improved quality of life. And what we looked at, what we had gathered was information based on their medical history, their functional history, manual muscle testing. We did a 30-second sit-to-stand test, single leg stance measurement, either a 6-minute, 3-minute walk test, or sometimes just a timed up and go, pelvic floor screening, and a lymphedema risk assessment. Again, within oncological rehab, to carry over some of what we had done in that study, is that we really want to look at what the patient's pain is or pain may be going through cancer treatment, what's going on with their scar tissue and how we can improve that connective tissue quality, and additionally those myofascial restrictions that may not come directly from the scar tissue, but other modes of the treatment like radiation and also chemo. We want to look at range of motion deficits that may be caused by any of the modes of treatment. We're looking for muscle weakness and atrophy. We want to prevent fatigue and give strategies so that patients can be as well as possible. And again, we want to prevent lymphedema, and we want to make sure that any pelvic concerns of bowel, bladder, sexual function are talked about and addressed per specialty. So, the first 7 bullets are really in general oncology rehab, and then the lymphedema and the pelvic rehab would be a specialty within that oncology rehab, where we really want to make sure they're seeing a certified lymphedema therapist or a certified pelvic rehabilitation therapist. Just so you know, when you write an order for physical therapy, occupational therapy, or speech, we will be doing an evaluation, which is a formal assessment of their function at that time. And then we will make a plan of care, which is essentially the treatment plan that we want to help the patient buy into and incorporate into their lifestyle during cancer treatment to help them feel empowered and have some sense of control during this difficult time. Oncological rehab is very education and independence focused. It's individualized, so it's really broken down based on that patient's function, needs, medical history, their home environment, etc. Some patients need a little, some patients need a lot, and additionally, those needs change throughout the spectrum of their care. Within general oncological rehab, some of the tools that we use include complete decongestive therapy. This is mainly for any risks of lymphedema that come from surgery, radiation, and or chemo. We want to work with patients on improving their ability to get them out of the sympathetic nervous system, that fight or flight, get them into parasympathetics, rest, digest, heal, with relaxation techniques, and that's done with some pretty focused breathing activities that anyone can do at any point within their treatment spectrum. We want to get them a home management program. Again, we want them as independent as possible. We can do biofeedback with neuromuscular reeducation. Here at Palos Health, we have real-time ultrasound, so we can show patients their ability to move different joints and their ability to see what their muscles and connective tissue are doing. So we can provide actual visual feedback to patients based on patterns that may become dysfunctional from cancer treatment. We want to look to providing information and education on core strengthening program, which includes the diaphragm at the top with breathing, the 4 different layers of abdominals in the anterior support of the abdomen. Then we have pelvic floor awareness and just general information on how important our pelvic floors are. And additionally, the back extensors, including multifidi, just improving that ability to be strong within our core during cancer treatment. What may happen, or what we do see, is that if the core isn't being addressed and supported and stabilized, that we will see issues within more distal joints like shoulders, elbows, wrists, additionally within the hips, knees, ankle, based on compensatory strategies for a weak core. We also want to make sure patients are very independent with their stretching program. This may include breathing with movement that helps patients calm their nervous system down and apply very beautiful interventions onto areas of dysfunction comfortably. We want to provide information on posture and body mechanics. Make sure there are no other secondary pain or postural deficits or dysfunctions based on patients trying to compensate for their treatment. We can recommend all sorts of durable medical equipment in order to help patients be independent and do all of their ADLs independently. We provide extensive education on anatomy and physiology. We look at their function and their functional goals. Again, this is focused on what the patient wants, not what the therapist wants. We can discuss any behavioral modifications that will improve their health. Exercise, specifically with a home exercise program. And again, we really want to make sure patients know that there are multiple and extensive manual therapy techniques that we can use to improve the connective tissue that's been affected by cancer treatment, which includes fascial restriction correction. Lymphedema prevention is incredibly important for patients going through cancer treatment. Multiple studies show that patients are very concerned with lymphedema and this idea of having a visual large limb from having cancer treatment. So we want to look at risk factors, doing prevention, teaching patients about the different stages of lymphedema, and again, that treatment and the treatment and intervention. We all have lymphatic systems, and so we want to improve lymphatics even before the insult of cancer treatment affects the lymphatics. So if we can do deep diaphragmatic breathing, which stimulates the cisterna chyli, which is the central processing center of the lymphatics, if we can work on breathing and massaging, that optimizes the lymphatics. And then additionally, when there's been cancer treatment affects that lymphatic system, so either by radiation, chemo, or surgery, we want to then teach that patient how to manage that small deficit that's been created with the cancer treatment. And there's, again, you guys have seen the study that we know this will reduce rates of lymphedema, which is really great to tell patients. For treatment, tons of self-care, tons of education. We always have to balance, we don't want to be overwhelming, but at the same time, we want to be incredibly empowering to patients and let them kind of seek us out when they need more in-depth information. We want to teach them how to do self-MLD, which is manual lymph drainage. We want to teach them about the appropriate compression with them, and then having them be active with their compression, which is usually a home exercise program focusing on what their goals are, what activities they want to do. Additionally, here at Palos, the oncological rehab has specialties with lymphedema and pelvic. So as pelvic floor physical therapists, certified pelvic floor physical therapists, we are looking at bowel, bladder, and sexual dysfunction. So if there are any issues that are occurring from any of the treatments, we want to be there to help the patients, let them verbalize and say, hey, there is this issue because bowel, bladder, sexual dysfunction is not being addressed. So just asking those questions and then having a tool and a resource of if there are issues, yes, pelvic floor physical therapists, specifically those who are manually trained, can provide great treatment to help those patients. So we're looking to really treat any kind of issues with bladder leakage, urgency, frequency of urine, any kind of fecal incontinence, any kind of smearing, any kind of unwanted gas leakage, incomplete voiding, so not feeling like urination or defecation has been complete. If there's any pain is a big indicator that physical therapy needs to be involved. And then additionally, pain with intercourse or even decreased libido or interest in intercourse. These are all things that happen within cancer treatment. So we want to be able to address that safely and professionally with patients. Pelvic rehab is not the Kegel. This is a picture of Arnold Kegel. I've heard Kegel, Kugel, like all sorts of different ways to say his name. But this is Arnold Kegel. He was an OB-GYN out in the 40s, did a lot of writing and research, and found that after delivering babies, the pelvic floor muscles weren't working well, so he created the first biofeedback device. And with strengthening the patient's incontinence went away. So more importantly than just doing Kegels or squeezes is the ability to understand if they are using the right muscles, if they're aware of the area. So awareness is the first, that's proprioception. Coordination is, are they using the correct muscles? Range of motion is that length tension curve. Can the muscles relax in order to contract fully and relax back down? So all of Kegel's original work was really, he talked very well about the ability to relax and contract, although I don't think medically or when people are talking about Kegels now that that ability to relax the muscles back down before contracting them is discussed. Additionally, this is an area that we see a lot of restrictions and tone issues, hypertonicity specifically, based on holding patterns of tension or stress. That this is a really easy area to kind of put stress into our bodies because this is an area that most people are very disconnected from. So we see a lot of tone restrictions, issues. There can be unknown, there could be injuries that occurred there years ago, people never talked about, different patterns that aren't creating health and wellness for our patients. And lastly, just want to give you an idea of what patients have expressed. Erin B. stated, I will be forever thankful that I was connected to my lymphedema specialist, Lauren, after my double mastectomy. Unfortunately, neither of my surgeons nor my oncologist had prepared me for what might be needed after surgery and some of the complications that come from a mastectomy and lymph node removal. The support, physically and emotionally, that was provided was something I didn't even realize I needed until I came to see Lauren. I'm not sure where I'd be physically now, even though it has been 9 months in surgery, if I hadn't been treated for my lymphedema, cording, scar tissue, and pain syndrome. Based on my experience, I believe every woman who goes through any breast cancer surgery and or treatment should automatically be empowered with the knowledge and know the importance of aftercare. I didn't know what I didn't know until I showed up at her office. Another patient expressed, since I've been under her care, my lymphedema has improved tremendously. In fact, I will have to order new sleeves and gloves soon since the size of my left arm and hand have improved so much. I am aware lymphedema cannot be cured, but with Lauren's expertise, I know it can be managed well and not progress any further. So to send your patients to physical therapy, occupational therapy, or speech, please find out who's in your area or reach out to me. I would love to connect you to different, you don't have to use us here at Palos Health. You can use other local resources, find who's in your area. We want to be there to, help your patients and to say just how amazing it was that they were sent to us from their physicians. Multidisciplinary care has been shown over and over to be the best care for patients. So when referring patients, it is important to know that we need an order. It can be an electronic order in Epic as long as it goes to a scheduling folder, which you would have to talk to your institution about that. You can also print out the Epic order, and patients can take that Epic order to any therapy department that offers oncological rehab, or you could provide a written order. And what we need is the patient's name and date of birth and what type of therapy you're recommending. That type of therapy is usually based on the resources that you have locally. Then you want an evaluate and treat written on the form, unless if you have specifics that you want identified. Otherwise, just put evaluate and treat with a signature that's dated. I am so grateful that you took the time to listen to our training on oncological or cancer rehabilitation. Please know I can be reached at any time via email, lmansell@paloshealth.com. And additionally, the main rehab number here is listed, 708-923-5050. Please know that we are wanting to be on your side and part of your team to provide the best care to your patients. We want to tell them how amazing you are for sending them to us so that we can start optimizing patients and improving their function and helping them have one small area of control within the realm of their cancer treatment. Again, greatly appreciate the time and energy that you gave me for this training and look forward to speaking with you at any time you need.